Thank you so much for joining us. We have over 700 healthcare providers from 65 countries that registered for this event. And Cleveland Clinic is a global institution, as you realized last week when the faculty was dialed in from different places. We would like to thank our corporate sponsors for the generosity in providing educational grants for this series, including Ferring Pharmaceuticals, Medtronic, Bristol Myers Squibb, Janssen, and Olympus. And this program is organized by Dr. Ben Cohen, co-section head for inflammatory bowel disease, Dr. Miguel Reguero, the chairman of our department, as well as myself. I'm Florian Rieder, co-section head for inflammatory bowel disease. We have two main themes today. One is dysplasia and inflammatory bowel disease, and one is post-operative recurrence in inflammatory bowel disease. And due to the high volume of questions during the last week, we in fact added an extra bonus 15 minutes to this format, and this would also be reflected within your CME credits. Without further ado, I would like to introduce the first speaker. I heard he has given this presentation for the first time, so we see how well he is going to do. This is Dr. Miguel Reguero. He's going to talk about post-operative recurrent inflammatory bowel disease, but jokes aside, as you know, Dr. Reguero is a global leader in this space, who is the main author on the pivotal trials in post-operative recurrence in Crohn's disease, and we are looking forward to his take on this topic. Please, Dr. Reguero, take it away.
Great, and as I get my slides ready to go, I just want to welcome everybody again to our live program. For some of those on the line, this is a repeat or a second time for you from last week. For those that are joining us for the first time, we really are looking forward to another great program. And as I think we continue in this virtual world, at least for a while, these types of programs will probably continue, I would guess, into the most of 2021, if not all 2021. I also want to thank Florian and Ben Cohen for putting this together. I think these interactive programs are nice, and everybody seems to enjoy them. As I saw Florian just pop up on the chat box is live and active, so please enter your questions as we go along. We'll certainly give time either during the cases or in between each of the presentations. So in the next 10, 11 minutes, I'm going to provide an overview on post-operative Crohn's. As Florian joked, this is something that I've been near and dear to my heart for a number of years. Some of you have seen this before, but if not, for those that are just joining IBD as a caregiver or somebody learning about IBD, I'd like to provide a high-level overview. So to start off with, natural course of post-operative Crohn's disease, I think most of you have understood this, but just to put this and ground this into the understanding of how this is, if you imagine you see a patient in your clinic and look at the red arrow on the left-hand side of the screen, imagine a patient undergoes an ileocecal or an ileocolonic resection with a primary anastomosis. For that split second, assuming that there's no other Crohn's in the intestinal tract, for that split second, the patient has, used to be, we said, curative Crohn's, but essentially now they're in a deep remission. But look what happens as you move to the right over time. There have been studies that have shown actual biopsies from the neoterminal ileum, even as early as 1 week after surgery, already show evidence of postoperative Crohn's. Moving further to the right by about a year, we know that up to 90% will have endoscopic activity, and ultimately they'll have tissue structural damages that show on radiographic images. Symptoms recur, and then the patient often requires another surgery. I think when you see the yellow arrow up top, this is an important key take-home point, that many of our patients will actually be clinically silent, meaning they will not have symptoms, and if anything, they'll tell you often this is the best they have felt for years, although we already know the recurrence is there if we do endoscopic evaluation. How do we consider grading or scoring postoperative Crohn's disease recurrence? This is really a tribute to Paul Rutgerts, who, as many of you know, passed away this year, but has been a leader in IBD and especially around post-operative Crohn's disease. And this is his study, the pivotal study from 1990, which really defined a low risk for post-operative recurrence versus a high risk for recurrence based on endoscopic findings at 1 year. Simply put, this means evaluating the anastomosis and neoterminal ileum and essentially describing what you see. So 0 is normal, 1, a score of 1 is less than 5 ulcers, and then you can see high risk progresses from there all the way to the point of deep ulcers, narrowing, stricturing disease, which would be considered an I4. We have adopted this score so that 0 and 1 we refer to as remission and 2, 3, 4 as recurrence. Although the score is not validated for that, you'll see us discuss these terms. So what are the approaches in a simplistic, basic way to postoperative Crohn's? Really includes starting treatment 2 to 4 weeks after surgery versus waiting until there is evidence of endoscopic recurrence and then essentially treating at that time point by which you see recurrence. The main question is what type of treatment, and I will not go through all of the treatments that have been studied in post-op Crohn's, but really get to the 2 that have been primary as far as showing efficacy, and those include antibiotics as well as biologic therapy. Well, antibiotics have been evaluated in many studies, ornitazole, metronidazole. We know the microbiome plays a role. And interestingly, this is a study from the Chicago group showing low-dose metronidazole may actually prevent recurrence. Now, this was retrospective. It's not a prospective study, but as little as 250 milligrams 3 times a day showed a prevention of endoscopic recurrence. One thing I would caution, many patients don't tolerate even low-dose metronidazole, and the benefit of metronidazole essentially stops when the medication is stopped. So it's not as if 3 months prevents post-op Crohn's forever. It's just when the patient is taking this. Another treatment strategy has really evolved out of anti-TNF therapy, and I think we've seen this before and described this before, but this is probably the best studied medication. This is our infliximab study that I published back in 2009, which was a small 24-patient study where half the patients who underwent an ileocecal resection were randomized to IV placebo for a year, and then the other half to infliximab. And just to cut to the bottom line, the primary endpoint was endoscopic recurrence. So again, endoscopic recurrence, 2, 3, or 4, a score of 2, 3, or 4. And you can see a very sharp distinction between the red placebo and the yellow infliximab. Now, this is a small study. This wasn't meant to be the pivotal study, but this was hypothesis generating and ultimately led us to the large international trial that Florian mentioned up front, the PREVENT study, which is so far the biggest post-operative post-operative trial we have. One important endpoint is the primary endpoint of clinical recurrence, meaning symptoms. Now, you heard a minute ago I said, why would you ever measure clinical symptoms? But some of this was actually driven by the FDA at the time with an interest in getting approval for infliximab on label for post-op Crohn's. I think most of us wanted an endoscopic primary endpoint. Nonetheless, these are the endpoints from the study. The blue bars are placebo. The gray bar is infliximab. And if you focus on the left-hand side, that's week 76. So obviously a bit over 1 year. But you can see essentially there's no statistical difference between placebo or infliximab. A couple of important points though. Look at how low the recurrence rate is for clinical symptoms. What I said a minute ago holds true. If you do nothing at all, meaning placebo, only 20% of the patients have symptoms at a year to a year and a half. The other thing is you start to see a trend towards infliximab showing lower, although it did not meet statistical significance. Well, what about the hard endpoint of endoscopic recurrence? And I think this is where we start to see the separation that we've seen before. And on a biologic level, the blue again is placebo, gray is infliximab. you can see there is a statistical benefit in infliximab at preventing recurrence. And a take-home point, if you were to ask, what's the endoscopic recurrence with anti-TNF at a year? It's about 20%. And this has been shown consistency across studies. And this, it was 22.4%. This is Ben Cohen's work, and I only put this up here. It's not for post-op Crohn's, but often the question is if a patient's on a biologic ahead of time or before surgery, does this increase risk? And this is the Puccini study, which maybe we can talk a little bit about in the Q&A. But the bottom line is that anti-TNF therapy and probably biologics in general do not impact complications in the post-operative period, and therefore we do not need to stop these prior to resective surgery. So that's early treatment, starting either an antibiotic or an infliximab biologic prior to surgery. What about the watch and wait? This is the POKER study. I'm not going to go through it in too much detail, but just to let you know, the real endpoint for this was an 18-month endoscopic endpoint. But the intervention was actually one group had a colonoscopy at 6 months, and based on that finding, there was an adjustment of therapy, meaning if there was early recurrence endoscopically. And the other group did not. Essentially, they waited the whole 18 months, then they had their colonoscopy. That's the bottom line. Is an early look beneficial? Some of the treatments I put at the bottom in terms of metronidazole for all patients, and if they were high risk for recurrence, thiopurines or adalimumab. But here's the bottom line take home from this. If you look at the left-hand side, these are the patients, and if you look at the red bars, these are the patients who had an early look at 6 months and then had a colonoscopy again at the end of study. And you can see there's a benefit and decrease in endoscopic recurrence. Does it matter which we give, infliximab or adalimumab? This is the Spanish study, and the bottom line is it does not, although adalimumab has not gone through the post-operative studies the way infliximab has. And just as I wrap it up, this really is the question. When is it too late to start post-operative treatment? Meaning, when is it irreversible damage? And we're still trying to figure that out. And I think we use risk factors to assess this. So after all these years and after all the data, really my approach to post-operative Crohn's disease has changed little, except I do not use monotherapy thiopurines, and I do look at anastomotic ulcerations a bit differently. What do I mean by anastomotic ulcerations? And we may have a case on this. This would be a score of ileal score of 2A, meaning the anastomosis only is involved. And interestingly, just to reference the study from this year, having just a ring of ulcerations along with the anastomosis did not drive long-term outcomes. However, many of these I2A patients will stricture over time, but they do well with a balloon dilation. So really, this is my post-operative algorithm. If a patient is low risk, first surgery, not penetrating disease, not their second, third, fourth surgery, probably leave them alone, do nothing else, but then 6 months after surgery, do a colonoscopy, and if they have evidence of recurrence, then treat. It's really the high-risk patients that I think we should treat post-operatively and be aggressive. These are patients with penetrating disease, especially those with 2 or more surgeries. Anti-TNF, specifically infliximab, has been studied the most. Probably use monotherapy, although the data is not as robust with monotherapy and proactive drug monitoring. I think that's reasonable. And then again, that 6-month colonoscopy. So I'll just leave this slide up for about 30 seconds as I conclude. And we know post-op Crohn's is recurrent. It's often silent. Penetrating disease and recurrent surgery is high risk. Smoking is the only modifiable risk factor. We talked about anti-TNF data in post-op treatment. Although there are vedolizumab and ustekinumab studies underway, non-invasive measures that we didn't discuss are small bowel ultrasound and fecal calprotectin to measure for recurrence. And then ultimately, the question will remain, which medicine's the best one, and can we wait in some patients, or do we have to treat up front? So thank you very much for your attention, and Florian, I will turn it back over to you.
So you mentioned the efficacy of antibiotics in the post-op setting, but this may only be short-lived. and they may not work long-term. So when do you use it in your practice? When do you stop them? For how long do you give them? How do you put this into your algorithm?
Right. So the data answer would be it would be reasonable to use metronidazole or nidazole, depending on what part of the world you're in, and probably low dose is effective post-op and use it for a few months. Now that's the evidence data. I will be very honest and tell you I've largely abandoned post-op antibiotics because most of my patients won't take them, they don't tolerate them. And again, as you allude to, the benefit is really only while they take them. So for those researchers out there, finding the microbiome altering agent that's well tolerated probably will be a good treatment for many Crohn's patients, and maybe that's going to end up being diet, quite honestly. But nonetheless, that's a separate discussion about the microbiome.
Yeah, I fully agree with that approach. And in fact, regarding the microbiome, Dr. Klick, who is going to be part of the panel later on, may be able to talk about novel therapies in the pipeline in the post-op space, modulating how bacteria are sensed in the post-operative space and how that could prevent recurrence. So another question I'm wondering about, Dr. Reguero, is how do you dose biologics in the post-op setting? So one could argue that do you need a full induction dose because the inflammatory burden determines trough levels and antibody formation and so forth, and we have a reset after resection and reconnection in these patients. So when you, for instance, start someone that is anti-TNF naive, you talked about infliximab, adalimumab, do you use a full induction regimen? Do you start with a lower dose? How do you handle that?
Yeah, that's an excellent question. I'm actually glad that you brought that up. In the PREVENT study, I actually didn't mention this, but it's important to note in the PREVENT study, we did not use a 3-dose induction. It was straight out of the gate, if you will, every 8 weeks at 5 milligram per kilogram. So you still saw that large separation. And the thought at the time and the FDA's guidance was, the feeling was use the minimal dose necessary. In my practice, I use standard 5 milligram per kilogram, 0 to 6 weeks. I do use a loading dose. And if I use monotherapy and infliximab, I will do a post-induction therapeutic level. And ideally, I'd want the level between 5 and 10, depending on the drug assay, and closer to 10, the better. But most of these patients without inflammation will have excellent drug levels, and you can likely maintain a standard 5 milligram per kilogram induction and maintenance.
So this is important information from clinical practice. So the last question before we move to Dr. Ashkar is about the symptoms in the postoperative setting. So the current classical symptom patterns, diarrhea, for instance, may not apply because patients can have increased numbers of bowel movements in the postoperative setting. So what do you use to determine clinical disease activity in patients that had an ileocolonic resection with an ileocolonic anastomosis?
A difficult question because the symptom complex and scoring validation in the post-op setting has been quite poor. And the reason for that you allude to is either patients have no symptoms and their disease is mild but recurrent, so they actually have active disease, or they have post-operative symptoms that may be bile salt diarrhea, pain from the surgery itself, visceral hyperalgesia, a number of symptoms, and even using the PRO2 of abdominal pain and diarrhea is flawed. So I think a reasonable strategy is you want the patient to feel well, but getting a fecal calprotectin as an objective measure at 3 months is reasonable, especially if you're wondering when you will do your colonoscopy, especially in a patient not on treatment. And without going through all the data, if the fecal calprotectin is over 150, certainly over 200, that should prompt you to consider an early colonoscopy at least 6 months, maybe even a bit earlier.
So this was excellent. And one thing I would like to emphasize from your take-home slide that is important for everyone that dialed in, if the patient is smoking, strongly encouraged to stop smoking in these patients because that's one of the strongest drivers, if not the strongest driver of recurrence in the post-op setting. So thank you very much for posing the questions. We're gonna answer those as Dr. Cohen mentioned in the case later. Thanks a lot, Dr. Reguero, for this great talk. We are going to move on to Dr. Ashkar. Dr. Ashkar is the head of education at the Cleveland Clinic and the Kenneth Rainin Endowed Chair for Inflammatory Bowel Disease, as well as our fellowship program director in gastroenterology. And he's going to educate us about dysplasia in inflammatory bowel disease. Dr. Ashkar, please.
Thank you, Florian, and thank you, Ben and Miguel and Florian, for this invitation to speak. And I think this is a timely topic because there's been some new data and in a way a paradigm shift in how we approach dysplasia and IBD. So an outline of what I'm going to do is talk about first surveillance. What should our approach be in patients with IBD? When should we start surveillance and how often should we do it? And then just as importantly, what technique should we be using when we do our surveillance in our IBD patients? Next, we'll talk about what to do with identified dysplasia. And then lastly, I'll present a lot of data, some of which is conflicting and confusing. So I'll try to give you some take-home points and my recommended approach for how to manage these patients. So let's talk a little bit about the past, where we were, 5 years ago, and not so long ago, 5-10 years ago. The general approach is some of these things still hold true, but when did we start surveillance? There was a little bit of a differential whether you had left-sided disease or more extensive disease as to when to start surveillance. Recommendations were to do it every 1 to 3 years, and the gold standard up until a few years ago were to do multiple biopsies throughout the colon, and particular attention to any elevated lesions. Limitations of that approach, in addition to poor patient adherence, which remains an issue, studies showed that many physicians did not take the time to do all those biopsies or to do in a systematic fashion. And the old approach was if we found any dysplasia, we would have a low threshold to refer the patient to colectomy. What has changed since then? Well, in large part, our technology has improved with the use of high-definition colonoscopes, enhanced imaging techniques. And then in addition, there have been studies that have shown the recognition that most dysplasia in IBD typically is visible. And we now know that endoscopic resection of lesions is effective and a feasible option in our patients. And just to highlight one of these points, most dysplasia is visible. These are a couple of studies, one from the UK and one from the US, retrospective studies looking at large numbers of surveillance colonoscopies. And when you look at the data, whether per patient or per lesion data, the majority, 80 to 90% per patient of the lesions, of the dysplastic lesions, were visible lesions. So with that background, where do we stand currently? And these are a few of the large society guidelines, acknowledging that the AGA ones are a little bit on the older side and are being revised. But you can see that things are a little more uniform now, with all the societies recommending initiation of surveillance after 8 years of disease, regardless of extent, beyond rectal or rectal sigmoid disease. So left-sided or more extensive, everybody ought to start at every 8 years. And there's also fair recognition of the surveillance interval. PSC, everybody should be done annually. It should be started at the time of diagnosis of PSC with concomitant IBD, and it should be continued on an annual basis. And then for non-PSC patients, we do see a little more of a smattering, mostly every 1 to 3 years still in the mix, but the European guidelines allow for lower risk patients to go out as far as 5 years in terms of surveillance. So we have pretty good agreement from that standpoint. However, what about the technique and how do we do this? And this is where things have been evolving. So our starting point here for recent data is the Scenic Consensus Statement, which was published in 2015. And I copied here some of the main comments, and their two strong recommendations were high definition colonoscopy is better than standard definition colonoscopy. And if you're using a standard definition colonoscope, they strongly recommend the use of chromoendoscopy rather than white light endoscopy. They also made two weaker or conditional recommendations and acknowledging that they had low quality evidence for these statements. And they said even with high definition colonoscopy, the consensus statement still recommended chromoendoscopy over white light colonoscopy. And they specifically came out and did not recommend NBI over white light colonoscopy or chromoendoscopy. So this, and I'm sorry, the other important point that came out of the scenic guideline is forcing us to think more with along the Pierce classification of lesions. And when dysplasia is identified, it's important to classify it as visible or invisible. And then when visible, is it polypoid or non-polypoid? And then further breakdowns as I have listed on the slide, as well as the descriptors of distinct versus indistinct borders and ulcerated or not lesions. So despite these recommendations from the scenic consensus group, and again, this was not a guideline, but rather a consensus statement, there's been confusion and there's been discrepancy as to how to approach things. This was a small survey of 40 experts that we did as part of the IBD Circle online. And we asked people, assuming that you're using a high definition colonoscope, what method are you using for dysplasia screening? And you can see still 30% of patients were using white light endoscopy and biopsies throughout the colon, and then a smattering for either dye, chromoendoscopy, virtual chromoendoscopy, and targeted biopsies versus still taking lots of biopsies. So even amongst people who take care of a lot of IBD patients, there still is uncertainty as to what the best way to approach dysplasia technique. And why is that? And that's because since 2015, when the scenic consensus statement came out, there have been several studies that have done some head-to-head comparisons of these different techniques. And we'll go over these, comparing high-definition white light to dye spray chromoendoscopy, high-definition white light to virtual chromoendoscopy, and then dye spray to virtual chromoendoscopy. So let's go through each of those, and I'll just give a summary slide or two on each of these. So 3 studies in the past couple of years comparing high-definition white light to dye spray chromoendoscopy. And you can see 2 of these were randomized controlled trials. One was a case control study comparing either high-definition white light to indigo carmine, or in the case control study, methylene blue and in the combination of indigo carmine. Some patients with either. And what you can see from these trials, one study did find a benefit to dye spray chromoendoscopy in dysplasia detection, the middle study here, with a difference of 5% to 16%. The other studies did not find a difference in technique. And then something we're going to come back to, notice these withdrawal times here, ranging from 15 to 25 minutes in these trials. And then a study that's in press, the Virtuoso study, which was a head-to-head comparison, randomized controlled trial, 94 patients in each arm to high-definition white light or virtual chromoendoscopy. And again, no statistically significant difference. If anything, maybe a little bit of a higher detection rate with white light than with virtual chromoendoscopy. And then what about dye spray versus virtual chromoendoscopy? And there are 2 trials that have looked at this, one randomized controlled trial, one a crossover trial where they brought patients back a second time for a second colonoscopy. And here we found no differences between the 2 techniques, dye spray or virtual chromoendoscopy. And again, notice these long withdrawal times. And then lastly, a study that has gotten some press. This was a randomized non-inferiority trial of all 3 different techniques done together in one trial. So high definition white light, high definition dye spray using methylene blue in the majority or indigo carmine in the others, or a high definition virtual chromoendoscopy. All procedures were done by one endoscopist, and they had 270 patients, 90 in each group. And what you can see here, the different groups, although there's minor differences, overall, when you look at this table, nothing major jumps out at you in terms of one technique being superior to the others. So kind of summarizing all of this, and I think explaining some of the discrepancy in how people are approaching this, my personal take of this, and it'll be interesting to see what the other panelists thinks, but to me, it's not clear that there is a particular advantage to any of these different techniques as long as we are using a high definition colonoscope. And my other take on this is the most important part of all this may be, and this is an earth-shattering recommendation here, but take your time, examine carefully, regardless of what technique you use. And in these prospective trials, withdrawal times were between 15 to 25 minutes. And that, to me, may be the most important part of all of this. So what do the society, coming back to this table that I showed, what do the society's guidelines now recommend? So the AGA, again, acknowledging that it's a little bit of an older statement, still says random extensive biopsies or chromoendoscopy with targeted biopsies. The British Society updated their recommendations in 2019 and basically said, follow this scenic consensus statement for how you approach this. And then the two more recent recommendations, the ECHO and the ACG from 2019, and you can see here, now they're starting to splay out a little bit more. So ECHO, dye spray chromoendoscopy with targeted biopsies. And if you're gonna use white light, they recommend going back to the old standard of 4-quadrant biopsies. ACG came out with a little more stronger statement, and we'll highlight that on the next slide. But basically, the ACG recommends that forget biopsies. You can do selected random biopsies, but not entirely clear that they help. If you're doing standard definition colonoscopes, they come out and agree with use of dye spray chromoendoscopy. But if you're using a high definition colonoscope, the ACG says that you can use either white light endoscopy with narrowband imaging or dye spray chromoendoscopy to identify dysplasia. And I'll come back at the end and I'll tell you kind of how I interpret all of this and how I put it together. So that's how, when, and we should be doing our dysplasia screening. Now, what do we do if we find dysplasia? And again, I'm going to reference back the scenic consensus statement nomenclature here. And the most important part of all of this is going to be whether we consider this visible or invisible dysplasia. So what does scenic consensus statement tell us? And this is, again, a paradigm shift here. And the recommendation, whether it's polypoid or non-polypoid visible dysplasia, if we can remove it, we can continue to follow the patient. We no longer need to be referring all these patients to colectomy. And then the trickier part is invisible dysplasia. So what do you do if you incidentally pick up dysplasia on a random biopsy or the 4-quadrant every 10 centimeter through the colon? And here they recommend following up with a chromoendoscopy, high definition colonoscopic exam. The theory being that most likely there is an underlying visible lesion that just wasn't picked up with a standard technique, and perhaps with enhanced imaging, we will be able to pick up a visible lesion. Similarly, ACG guidelines come out and say, as long as we can resect the lesion, proctocolectomy is not necessary, and we can follow patients closely. However, if dysplasia is not resectable or is multifocal, then reconsider proctocolectomy. And then the issue that we haven't talked about, but extensive inflammatory polyps pose a challenge regardless of what technique you're using with being able to accurately identify dysplasia. So putting this together, I put this in big, bold boxes here. So if you find dysplasia, the first question that we should ask, is it visible or is it invisible dysplasia? And our approach is going to be different. So let's follow the left side of the chart. If it's visible dysplasia, the next question is it resectable? If yes, a close endoscopic follow-up is all that is needed. We do not need to be thinking about colectomy. However, if we have visible dysplasia that is not to be felt to be endoscopically resectable, and nowadays we're kind of pushing the envelope with ESD and all kind, where do we stop that definition of not resectable? But if we feel that something is not resectable, those are the patients who should go on to colectomy. On the other hand, if it's invisible dysplasia, we should do a follow-up chromoendoscopy exam and ask, is a lesion seen? And again, if a lesion is seen, we're now back into the visible dysplasia category, and we can follow this algorithm again. But if a lesion is not seen with follow-up chromoendoscopy, I would definitely take biopsies in that area where the dysplasia was previously identified. And I think the easy one is that if there was initial or persistent high-grade dysplasia, we ought to be recommending colectomy. The tougher one is if it's low-grade dysplasia, and should we just recommend close follow-up? Should we pursue colectomy? And that's, I think, a shared decision-making process with the patient. And so putting this together, I will give you my approach on this, and glad to discuss further. Some of the obvious things, IBD with PSC dysplasia surveillance should start immediately. Everybody else with more than rectal involvement, and let's not forget Crohn's colitis with more than a third of the colon involved, we start after 8 years of disease and continue every 1 to 3 years, except for PSC where we're doing it annually. What technique should we be using? Absolutely high definition colonoscopes are advantageous. So if at all possible, be doing your exams with high definition colonoscopes. And what I've shifted to is I will examine segment by segment, initially with white light and then with NBI on withdrawal, taking my time, looking carefully for lesions, again, with the knowledge that most dysplasia is going to be visible. And if I pick up invisible dysplasia, or if a patient is referred in with invisible dysplasia, I think that's the time that it makes sense to think about dye spray chromoendoscopy. And then for the most part, targeted biopsies, although I think there's still some role for random biopsies for assessing the histologic extent of disease or histologic inflammation. So not necessarily completely abandoning random biopsies. And then if we identify dysplasia, again, is it visible or not visible dysplasia? And using these key classification terms in our reports is very helpful. So visible, polypoid, visible, non-polypoid dysplasia is helpful language to transmit, especially if a patient is going to be referred in for subsequent resection or chromoendoscopy procedures. And then this slide that I showed, the approach will depend on visible versus invisible lesions. And I kind of walked through this before, but just highlighting this approach again. And thank you.
Thank you very much, Dr. Ashkar, for this very practical talk with easy-to-follow algorithms, which I think is helpful for clinical practice. We're going to fit in a couple of questions before we hand it over to the case panel. And one critical question that also came from the audience in the chat box is, how do you handle the presence of pseudopolyps when you surveil patients? So does the number of pseudopolyps matter, location, and then a question from Dr. Appel. What do you do if you have pseudopolyps and you find low-grade dysplasia or tubular adenoma in a patient?
Yeah, so and this is a tough call. So pseudopolyps there's been some controversy with this, whether pseudopolyps in and of themselves are associated with dysplastic risk. And the answer is probably not. They're more associated with our inability to be able to perform a good exam and detect subtle dysplasia is the main issue. So there's pseudopolyps and then there's pseudopolyps. So, a few scattered pseudopolyps, regardless of location. And as long as we can kind of examine them, make sure there's nothing unusual appearing about them. If not sure, removing the polyp and submitting it to pathology just to double check is a reasonable approach. The tough ones are going to be the ones where you literally have carpeting of the mucosa with pseudopolyps. And those patients, they're the toughest patients because they feel good. They have no symptoms, but and they have no dysplasia. We're biopsying, we're looking, they have no dysplasia. But we're saying to them, I'm worried that you could get dysplasia, and we're trying to talk them into surgery. And in my experience, most of those patients usually aren't too keen on surgery. I think it's a risk-benefit discussion with the patient, and the right thing is to say, I don't think I can accurately keep an eye on your colon. We should consider surgery. And if the patient says, I don't want it, and then just carefully following them.
Yes, so a clear case for shared decision-making, because the risk of dysplasia is not increased when you have pseudopolyps versus not, but you just cannot see them as well in the surveillance strategy. So the last question before we hand it over to the panelists, what if you find a lesion, you completely resect it, and you find a sessile serrated adenoma? How does that affect your management in inflammatory bowel disease patients versus non-inflammatory bowel disease patients with sessile serrated lesions?
Yeah, it does not. So we should report the same as a tubular adenoma or sessile serrated lesion, as long as it can be endoscopically resected, and I'm comfortable that I got it all. We would continue surveillance. We may want to, watch them a little more closely. Do we bring them back at 6 months versus a year? Those are, I think, things that we can. You'd probably get different opinions, and that we can discuss, but they should be followed closely. And we did publish a study a couple of years ago that sessile serrated polyps were not associated with higher risk of malignancy. That we did have a higher risk of metachronous dysplasia. So just they need to be watched closely, but it wouldn't tilt me more towards colectomy or anything different.
Very good. Thank you very much. And please, Dr. Reguero, Dr. Ashkar, you stay on as part of the panel. We are hearing and reading all your questions in the chat box that are now going to be addressed by the co-section head for inflammatory bowel diseases, who is leading the discussion, Dr. Benjamin Cohen. And I'm very proud of him because today is the first day that I see him, in fact, in a white coat. This has not happened so far because he just started with us at the Cleveland Clinic in the inflammatory bowel disease section. And he's going to lead the discussion in a case presentation with Dr. Falloon, who is our GI fellow and soon to be inflammatory bowel disease fellow. So Dr. Cohen, it's all yours.
Thanks a lot, Flo, and it's great to have everybody from across the world here joining us for these virtual education symposia. And we're also pleased to have two additional panelists. So in addition to Dr. Reguero and Dr. Ashkar, we have Dr. Benjamin Click, who's part of our IBD section and doing a lot of work in risk prognostication in the post-op space, as well as Dr. Amy Leitner, who's one of our colleagues from colorectal surgery who's done work in dysplasia, and you all probably know her from her work with stem cell therapy for fistulizing Crohn's disease. So Katie, can we please have you take us through the first case?
Absolutely. So thank you so much for having me. I'm Katie. I'm going to be starting the first. So we have a 32-year-old male smoker with ileocolonic Crohn's disease for 5 years, present with a small bowel. He's on azathioprine, has been using steroids 1 to 2 times per year on top of that. So he undergoes a colonoscopy that shows inflammatory in the terminal are taken. The path comes back consistent with Crohn's disease. And he also has a CT scan that shows a stricture with upstream internal penetration. So he undergoes an uncomplicated ileocecal and with anastomosis. And the first question for the panel is, what medication would you start now?
Great. So maybe we can start off with Ben. If you could talk about your approach and how you risk stratify patients and what you would do in this specific situation.
Yeah, so thank you to everybody for the invitation to participate. A very interesting case. I think this situation highlights a couple of different risk factors that Miguel nicely reviewed for us when we think about patients who are at higher risk of early or aggressive postoperative recurrence. So this is a gentleman who's 32 and has had, I believe, 5 years of disease, so diagnosed in his late 20s. So when we think about age at diagnosis, younger than 30 has been shown in several studies to potentially impart a higher risk of recurrence after resection. This gentleman smokes, and as Dr. Reeder alluded to, that is a very strong risk factor in the majority of studies for early recurrence, and it is the only modifiable risk factor from a patient standpoint. And finally, this gentleman has stricturing plus penetrating disease phenotype, which, as we heard earlier, is a risk factor for early recurrence. So this gentleman, in my mind, has checked off 3 boxes for high risk for early recurrence. And this is a gentleman who I would be treating prophylactically, a la the PREVENT study with biologic therapy. And as Dr. Reguero nicely reviewed for us, the majority of the data in the postoperative setting is for anti-TNFs. And so this is a gentleman who I would be discussing anti-TNF therapy with. And then the choice of medication comes down to, similar to all of our clinical situations, what is the patient's life like? What are his preferences regarding infusion versus self-injectables? I, like Dr. Reguero, still do a loading dose followed by maintenance in the postoperative setting, likely with monotherapy, unless this individual has had prior biologic therapy with failures or anti-drug antibody formations. I still do monotherapy with a proactive TDM just to make sure I'm achieving a gold trough level. So anti-TNF monotherapy in this gentleman, the choice of agent depending on those patient risk factors, and then an early Calpro at 3 months followed by a colonoscopy at 6 months for him.
Great. A couple follow-up questions based on that. Just in terms of practicality, how soon after the surgery will you start the biologic?
Yeah, so great question. We actually don't have much data to guide us in what is the right time to initiate biologic therapy, as Dr. Reguero mentioned. For my practice, and similar to the PREVENT study, within 2 to 4 weeks of surgery, in my mind, is the ideal setting, early enough that we can hopefully alter the natural history of disease, but also gives the surgery some time to heal. I always check with my colorectal surgery colleagues to make sure there are no perioperative complications that may influence the decision to initiate biologic therapy. I think the important logistical point, at least in the US, is the insurance coverage and approval process. So this is a decision I actually make pre-operative. I don't wait until a post-operative follow-up clinic visit because biologic approval, depending on the system, can take weeks to months. And so I choose my agent, I talk about it with the patient before sending them to surgery, and I start the approval process even before surgery so that it's ready to go in that 2 to 4 week post-op period.
Great. Yeah, I agree completely. I think it's really important that we think about this well in advance and not wait till after the surgery is done so that we have a plan in mind, just because of all the logistical loopholes we may have in the United States in particular with getting patients the medications they need. Miguel, one of the questions that came up following your presentation was how you handle the choice of drug for patients who were on a biologic preoperatively. Now, that's not the case with this particular patient, but let's say patient was on infliximab before. Is that going to impact your decision on which agent you're going to use post-op?
Yeah, so I think it depends how you define failure. And I think the person asking the question was very appropriate in asking a patient who's failed anti-TNF or failed infliximab. So I look at failure as 2 definitions in the preoperative setting that will influence what I do post-operatively. So one term for failure is that just essentially it's a failure for us to take the patient to surgery early enough, and the patient's on an infliximab or any medicine, the damage has been too far gone. The patient probably needed surgery a while ago. And it's not a real failure of infliximab, it's just a failure of the disease to reverse, and usually the patient needs surgery. In that case, especially if it's been started within 6 months of surgery, I'll continue the post-op infliximab. And there are some studies that have actually shown that's effective. That's different than a patient who's been on infliximab, has had good drug levels, and you've seen very severe inflammatory disease or deep ulcers that you've seen kind of more or less before your eyes progress to the need of surgery, where there's truly a progression despite having adequate drug levels of infliximab. So true primary non-responder, that would be somebody I would probably switch out of class and not use an anti-TNF. That's only about 10 to 15% of our patients. 85 to 90 have disease, too far gone, probably needed surgery. Patient may not want surgery. We try the infliximab as a last ditch. It's not working. I would continue that post-op. That's not a true failure.
Great. And Amy, another question that came up from the presentation was about whether there's a need to perform any kind of cross-sectional imaging post-operatively before we start medical therapy. Are there situations where you would recommend that? How do you approach that with us when we're making that decision?
Yeah, I think it really depends on how the patient is doing clinically. So we typically see patients post-operatively around week 4 to week 6 for their standard post-operative visit. If they are relatively asymptomatic, meaning no fevers or no change in their abdominal symptoms, I wouldn't recommend getting abdominal imaging at that time. But certainly, if they're having fevers or a change in their symptoms, that would prompt us to get perhaps serum labs drawn. And if they had an elevated white count with fevers, I think that would definitely prompt me to get abdominal imaging and see if there's a phlegmon or a flexion there that we should drain prior to initiation of biologics.
Great. So Katie, why don't you tell us what happened next with the patient?
To pursue any medical therapy after his surgery. And so we went ahead and did a colonoscopy at 6 months for him that showed ulcers confined to the anastomosis, graded as a Rutgers I2A. So with that information, what would you do next for this patient?
So Dr. Ruggiero touched on this during the presentation. I think this has been a point of controversy over the last couple of years. So Miguel, maybe you can take us back through what you discussed during your presentation. Do you consider this to be recurrent Crohn's disease? Do you think this is some other entity? How do you approach it?
Yeah, so I think a general concept that I think all of us should remember when we talk about post-op Crohn's, surgery itself for Crohn's is not curative. Unfortunately, we still don't have the cure for Crohn's. It's just the implication is after surgery, how long will it take for recurrence? And is the recurrence so mild the patient may not need treatment? So just to make that statement. The second statement is when we see inflammation along the ring of the anastomosis, that is recurrence. It used to be called that we thought it was ischemia or some vascular changes or anatomic changes based on the surgery. But I think the more we understand this, that really is recurrent Crohn's disease. So one of the differentiations in the Rutgers score is I2, remember, is 5 or more small little ulcers or significant ulcerations. If it's confined to the anastomosis, so above in the neoterminal ileum or below in the colon, if you're doing a colonoscopy, is normal, just along the anastomosis, that's I2A. So think of A for anastomosis. I2B would be, yes, you see them at the ulcerations at the anastomosis, but it extends usually above into the neoterminal ileum. And then that would be a patient that would be treated like anybody else, and I would consider that a significant recurrence that requires treatment. So yes, I2A, anastomotic only ulcerations is recurrence, but I think based on the study I showed in my own practice, most of these patients probably don't progress quickly, and you probably can wait. However, there is some controversy. Some groups have found that will progress, others will not. I think it's somewhat a judgment call. The photo that Katie you showed shows like it's maybe a little bit more inflammation than I'd like, aside from a couple little dots. So, I could say it's an I2A plus. I don't want to confuse this because there's no such score, and say I'd make a decision on treatment. The patient's going to tell you he probably feels great, he probably doesn't want treatment. There is evidence of that. If he really still is resistant to treatment, I'd be curious to see what a fecal calprotectin is now. It might be elevated because we see that, but use that as a marker going forward. And definitely at 6 months to a year, again, I would do a scope. And if there's further progression or inclusion of the neoterminal ileum, I would treat.
JP, so in this case, the patient didn't get biologic therapy post-op, and these were the findings on colonoscopy. What's your approach in terms of surveillance if you're going to start a patient straight off on a biologic or wait for that 6-month colonoscopy? Do you monitor them differently in the interim?
Tell me again, in terms of how I'm going to endoscopically follow them?
Or endoscopically, clinically, biomarkers. Are you gonna watch them differently if you haven't put them on stop therapy versus if you put them right on a biologic?
Yeah, so I think certainly if I'm not putting them on a biologic, that definitely at 6 months I'm bringing him in for a colonoscopy. If I put them on a biologic, I think the right thing is say 6 months, but maybe I'll get a little lazier and let it stretch out to a year before I bring them back for that follow-up procedure. And then just to echo what Miguel said, the anastomotic disease only, and although this one may be a little more dramatic than most, that by itself wouldn't push me to necessarily change things. If they were on therapy already, can we optimize things and so forth would be all that I would do. But in this guy who's not on treatment, it wouldn't change my mind. I don't think I'd be jumping into treatment. But I would agree. What we don't know is this the first sign that this guy's progressing on me, or is this he's going to stay like this for many, many years and he's not going to progress on me? So I would, in this particular guy, no treatment, an anastomotic recurrence, I would bring him back in another 6 to 12 months to relook again, just to make sure that he's not progressing on me.
Amy, do we know anything about the type of anastomosis and how that may relate to these anastomotic ulcerations that we see? Is there anything that we should know from a surgical perspective there?
I think when you see the ulceration, kind of the ring of the anastomosis, that's definitely on the staple line. I don't think you get as much of that distinct ring with a hand sewn end to end as you do when you have a staple line. In terms of recurrence with the type of anastomosis that we do, see the most common type of anastomosis is stapled side to side, just for ease of construction. There's now 2 different things being studied with regard to postoperative recurrence. One is this Kono-S anastomosis, which is a different type of construction that creates a little bit of a mesenteric bridge and is a hand-sewn anastomosis that is effectively like an end-to-end. And there's actually been a randomized controlled trial showing that there's decreased postoperative recurrence on 6-month endoscopy. There's more trials underway, I think, to confirm those findings. And another thing that's being studied is the extent of the mesentery that we take at the time of resection, and kind of that diseased mesentery that we see that creeps over the bowel wall. So I think we'll see more of those things as a way to potentially surgically try to help with this postoperative recurrence that we see.
Great. And Ben, I want to give you the last word. We alluded to it after Miguel's presentation, but is there anything in the pipeline in terms of other approaches for treatment of postoperative Crohn's disease, maybe apart from our traditional biologics?
Yeah, so there's a lot being investigated from the basic all the way to clinical trial. There's a lot of interest, as Miguel alluded to, in altering the microbiome. There is some early evidence that certain bacterial signatures increase the risk of early recurrence, one of those being adherent invasive E. coli. And that's been shown to be present in up to about 70% of individuals with Crohn's disease, in the presence and activity of that organism does associate with early recurrence. So there's a clinical trial ongoing that's evaluating an agent that helps bind and clear these adherent invasive E. coli organisms. There's other various stages and phases of trials looking at other agents such as bacteriophages, targeting some of these other organisms as well. So there's a lot of active investigation. Some are closer in the pipeline than others, but we anxiously and eagerly await their outcomes to see if that's going to be a proven strategy.
Great. So that was an excellent summary of that case and of post-op Crohn's disease. And with that, Katie, maybe you can take us to our second case about dysplasia.
Our second case is he's a 42-year-old gentleman. He has an 11-year history of ulcerative colitis. He was initially placed on mesalamine and Imuran, and ultimately on Remicade, which he's been on for the last 8 years with good clinical control of his disease. He had and at that time he was in endoscopic remission as well. Next slide, please. So at an outside hospital that shows mild active inflammation throughout, it's graded as Mayo 1, and random biopsies are taken pattern with colitis throughout the colon. And in the ascending colon only, the biopsy report also reads low-grade dysplasia. So the for that you do next.
So JP, maybe you could take us through your approach with this patient.
Yeah. So one thing I did not talk about in my approach. So what catches my eye is this guy has inflammation. And the question is this really low-grade dysplasia, or could these be reactive changes? So another teaching point that's important, low-grade dysplasia should be confirmed by a second GI pathologist before we get overly excited and push it. So the first thing I would do is confirm low-grade dysplasia. If low-grade dysplasia is confirmed, then as per the protocol that I lined up, he should be brought back with a high-definition chromoendoscopy exam performed with a particular focus in the ascending colon where that dysplasia was found, with the thought that most likely there is an underlying visible lesion that was not seen on the routine exam. And hopefully, if we can identify that visible lesion, we remove it and then we go with close follow-up. The other thing is I would make an effort to get his inflammation under control before I did that inflammation, just to remove that as a variable as well. So he has mild disease, and can we optimize his anti-TNF? Is there anything more that I can do to knock that inflammation down before I bring him back for that repeat colonoscopy?
So will you not do, as a general teaching point, if a patient is inflamed, will you defer their dysplasia surveillance?
Yeah, if it's mild, in fact, it sounds like this guy's was mild, I'll probably go ahead. But I'd say anything more than mild, yeah, we shouldn't be spending time doing dysplasia screening at that time.
And as a practical point for the audience, since this is IBD basics and beyond, how do you actually perform the dye spray chromoendoscopy? Like the dilution, what do you use?
Yeah, so the either methylene blue or indigo carmine. The one that we have readily available to us here is the methylene blue. And there's the scenic consensus statement within their document has a nice kind of recommended algorithm for how to dilute and what different concentrations that you can use. So the recommendation is 10 mLs of 1% methylene blue mixed with 240 cc's of water as the dilution to give you a good screen throughout the colon. The scenic consensus statement, they have a beautiful picture of putting the methylene blue in the water jet bottle, and then you can just spray, you can push on the pedal and spray it through there. And that would make life a lot easier, but in the era of scope disinfection, at our institution, and I know at other institutions, but not all institutions, we are not allowed to put methylene blue in the dye spray bottle. So unfortunately for us, we have to put a catheter through, use a spray catheter and push the dye through, which makes it more of a headache because you have to put the catheter in, flush, and then if you see something, you have to pull the catheter out, put your biopsy forceps in, and then put your forceps back in. So it adds to a little more challenge from that standpoint.
Great. Ben, if you could give us your thoughts on surveillance intervals. So in colon cancer screening guidelines, we adjust the intervals based on the findings of the exam. If you have a patient, let's say they've had multiple negative screening or surveillance colonoscopies for dysplasia, how does that change your approach?
Yeah, so I think it depends on that individual's baseline risk for dysplasia, neoplasia. So is this a PSC patient? Do they have a strong family history of colon cancer? So I think some of those baseline factors, is this a UC patient with a stricture, for example? So some of those factors influence the answer to that. So a PSC patient I'm doing annually regardless of findings, for example, and similar with the other high risk factors. But let's say it's an average risk individual just based on disease duration. Then generally, if you look at the European guidelines compared to the US societal guidelines, they do start to space individuals out who are confirmed low risk with no prior dysplasia history out to that 3 to 5 year time span. So in an individual who's well controlled, displays endoscopic and even histologic remission on some random biopsies that I typically obtain every so often during my endoscopies just to confirm that, not necessarily for dysplasia screening purposes, then I will start to space those people out generally to that 3, maybe 5 year mark, depending on an individual, but generally in the 3 year range.
Great. And then I guess we can ask the panel across, are any of you still doing random biopsies? So maybe Miguel, you can start.
No, not the way we had before, every, 4-quadrant every 10 centimeters. I actually do exactly what JP said in his talk. The time that I'll do random segmental biopsies, which is 2 to 4 biopsies, not every 10 centimeters, is more for histologic activity, given the thought that there is some evidence that histologic activity could prognosticate in terms of dysplasia in the future. And this comes up a lot when patients want to stop treatment. I'll use that as an indicator if they have histologic activity not to do that. But otherwise, no, I'm not doing every 10 centimeters.
Ben, are you doing 4-quadrant biopsies?
No, exactly what Miguel said.
And I don't want to leave out our surgeon. So are you doing 4-quadrant biopsies?
I'm not doing surveillance. I'm sending them to you guys.
Katie, why don't you take us and let us see what happened with the patient?
So we ended up pursuing a colonoscopy Crohn, and it showed a nodular ascending colon with no lesions seen. Random biopsies were taken there, and pictured here is the nodular fold that was seen in the descending colon. So once again, the path came back with some chronic present dysplasia in ascending colon, and there was low-grade dysplasia from the biopsies of that nodular fold. So what would be your next steps in this?
So JP, seeing that picture, what do you think you'd do with that?
I don't see the entire right rim of that lesion, but the question, okay, so now we have 2 issues here. We had invisible dysplasia, low-grade dysplasia in the right colon that we did not find on a subsequent exam. So that's one issue here. Am I allowed to ignore the initial low-grade dysplasia in the right colon? And then now we have this nodular fold. So in a way, you could make an argument that this is multifocal dysplasia and ought to be considering colectomy. So this is not so straightforward and a tough call. The next question is this nodular fold. It's visible dysplasia, and so is it resectable or is it not resectable? And the reason I say it's a tough call, the picture, I don't see that entire right rim of the lesion. The picture we saw of it, or the image we saw of it, it does look like it's potentially resectable, and it may be one where I'd send it to one of our advanced endoscopists to see if they would be able to kind of carve that lesion out of there. And if we carve it out of there and we're comfortable that we got it all, knowing that I still had the issue in the right colon, it may not be unreasonable to keep an eye on things. So again, a tough call. This is a one where to talk a little bit more with the patient, risk stratification, how are we going to approach things.
And one of the chat questions asks if your approach changes if it were high-grade dysplasia rather than low-grade dysplasia.
Which one, the invisible or the high grade? Now, so the nodular lesion, if low grade or high grade, as long as I can resect it, no. The invisible dysplasia, yeah, I would. High grade makes me more nervous, and I would tilt more to recommending colectomy for high grade.
Ben, would your approach be any different?
No, I agree completely with what JP said.
And traditional teaching with regards to dysplasia in UC patients has been to do a total colectomy. But now with our improved surveillance techniques, Amy, is there any role for segmental resections in UC? What have you seen?
I've seen this used on occasion in patients that are high risk. So a patient that is older, that has significant comorbidities, that may be at high risk for a total colectomy. I think that we don't really have enough data yet on segmental to know if we can actually recommend that as standard practice. But I think that in select patients, it may be reasonable. If they have low-grade dysplasia on the right side, it may not be resectable and you want to do a right hemicolectomy in a patient that's at high surgical risk, that could be considered. But I think that until we have more data, it's not yet standard practice.
And Miguel, so let's disregard the visible lesion that we saw there. If you have a patient that comes to you, they have a low-grade, they refer to you, they had a low-grade dysplasia on a random biopsy, you repeat a chromo exam and you don't find anything, what do you do with that patient?
Yeah, I mean, I think it depends on other risk factors, but let's assume there's nothing else and you don't see it again. We see this all the time. I think the old answer used to be we always sent them for colectomy, but that's hard in a patient who's in remission doing well. The practical answer today is I tell them one of two things. Either we're lucky and this actually somehow regressed, or you had some inflammation, or maybe there was a small adenoma that subconsciously we saw, we biopsied and it's gone. Or there is still dysplasia. We're just simply missing it despite chromoendoscopy. I don't send them to colectomy. I wouldn't wait 3 to 5 years for a colonoscopy. I would bring them back in a year. I would do another chromo. And I think for low-grade dysplasia, first time, no other disease, I think a year is fine. You could argue 6 months if you really want to make sure, but I would just do a repeat chromo at 6 months to a year.
And then maybe we can go to Amy. This is jumping outside the case altogether, but in terms of J pouches, how should we be approaching surveillance for dysplasia in J pouches?
So I think that's also a bit controversial when you look at the societal recommendations. There's definitely variability in the frequency of surveillance. So some recommend every year, some it's 2 to 3, some 5. So I think that when you look at all the recommendations and try to summarize them together, a patient that had dysplasia or cancer at the time of colectomy, in general, we would do surveillance every year on that patient. And some would argue dysplasia and PSC, you should do it every year. And I think that when we do surveillance, it's really important to really surveil the cuff. And sometimes that can be challenging on pouchoscopy, and especially if you have a tight anastomosis. So I think that surveillance of the cuff, we definitely take in mind to do the best job we can with that.
Great. We want to thank everybody that's participated in the panel and everybody viewing from across the US and across the world. Looks like we utilized those extra 15 minutes well, so we're about to end right on time. So maybe Steve, if you could put up the final slide. So we just want to remind everybody that you are going to get CME credit for participating in the program tonight. You can just use your QR code scanner, point your camera at the screen, and that will make it an easy process for you to claim your CME credits. And this qualifies for American Board of Internal Medicine and American Board of Pediatrics, MOC. We want to remind you that we have a few more exciting programs to look forward to. So in February, the Live from Cleveland Clinic is going to be a diverticulitis update, medical and surgical management, put on by co-directors David Rosen and Scott Steele. And then in March, we can look forward to our second annual IBD Masterclass, focusing on medical and surgical team approaches to complex IBD. And we hope to have more interactive, lively seminars over 2 nights, Monday and Tuesday, March 15th and 16th. And we hope you'll join us there. So thanks, everybody, and have a great night.